question is that coronary bifurcation lesions are one of the difficulty of the interventional therapy. Would you please to share us the latest research developments, including the IVUS, OCT, or FFR, research outcomes?
Yes, as all of us know, bifurcation is one of the most challenging subsets of PCI, accounting for 15 to 20% in the cath lab.
Yeah.
And still the current recommendation supports provisional stenting that stems from two large trials like BBC1 and Nordic1, which found provisional to be better than two stent technique.
Mm-hmm.
However, it did not differentiate into true and non-true bifurcation.
Mm-hmm.
And EBC2 also found that two stent technique did not improve the outcome as compared to the provisional technique.
Mm-hmm.
In Nordic 4, the result is same. I mean, two stent technique is as good as provisional, and here the side branch was 3.75 millimeter or larger. However, there was lack of proximal optimization technique, lack of IVUS, and that time ticagrelor are not available, so clopidogrel was used.
Mm-hmm.
Then the DK Crush series came. So DK Crush, in DK Crush 1, DK Crush was found to be superior to provisional technique in terms of mass, instant restenosis, and stent thrombosis. Similarly, in DK Crush 2 also, DK Crush was found to be superior to provisional at 5 years in terms of TLR and TBR. And DK Crush 3 was a landmark study for complex left main bifurcation, where DK Crush was found to be superior as compared to Culot, and in terms of stent thrombosis and in mass. Then came DK Crush 5. So that is again very good study that compared DK Crush with provisional and found it was found to be superior. And in terms of target lesion failure and target vessel MI, stent thrombosis, and angiographic instant restenosis. So now we confront with definition 2 trial, where again it was tested against other two stent technique in complex bifurcation lesion. In this trial also, DK Crush was the most used technique, and it was found to be superior as compared to other stent technique so far as target lesion failure is concerned. And IVUS plays an important role in bifurcation lesion, mainly left main bifurcation. If you go through main compare study, it reduces death and saves life. IVUS as in case of left main bifurcation. There are many studies showing improvement in death and mass with IVUS as compared to angiographic results. And DK Crush 6 is a trial that actually looked for FFR guidance bifurcation angioplasty, and that was found to be superior as compared to angiographic guidance.
Yeah, I think IVUS or OCT guidance may be important for the left main bifurcation lesions.
Yes. Yeah. I do agree. OCT, first thing it can select the entry of guide wire, whether it is likely to cross the proximal strut or distal strut, that is clearly visualized, so that we are not abluminal so far as guide wire crossing is concerned. And it will optimize the results also in terms of stent apposition and expansion.
But sometimes the size of the side branch and the main branch is very, the size is maybe it's bigger and the smaller. So the protection and the treatment of the side branches are particularly important. Would you please to share us the significance and the tips of the side branch protection in the bifurcation lesions treatment?
Yes, I can agree. Sometimes side branch is small and sometimes side branch is big, as in case of left main bifurcation. In left main bifurcation, side branch is as important as the main branch, so far as the size and territory of the myocardium supplied is concerned. And it is important to define the ischemia more than 10% in the side branch.
Yeah.
So that the patient would benefit from the PCI. Now, currently from the Korea, they have calculated fractional myocardial mass. That is the myocardial mass supplied by specific vessel. If it is calculated in the CT angio, if it is more than 10%, that means side branch is significant.
Yeah.
Okay.
Yes.
And in case of left man, most of the time side branch it is more than 10%. That is fractional myocardial mass. But in non-left main bifurcation, 1 out of 5 cases we have significant side branch. So side branch protection becomes important. There are few techniques. One in gel wire technique, that is most commonly we use.
Yes.
Another is gelled balloon technique. So semi-compliant balloon is placed in the side branch, either or with partial inflation. It can also protect the side branch. Another is active plaque transfer. That is, in this technique, what one balloon, compliant balloon is placed in the side branch, then unexpanded stent in the main branch. So initially we inflate the side branch balloon, then followed by inflation of the stent. Then we deflate both stent balloon and side branch balloon. Okay. Then take out the wire plus balloon. Then now address the now address the main branch with proximal optimization technique. So this is called active plaque transfer from side branch to main branch. Another is you modified balloon stent kissing technique. Here the stent and balloon are inflated at the same time. Then afterwards it was deflated and both the things are taken out. Then main branch is post dilated as per the proximal optimization, and this prevents peri-procedural maze and side branch occlusion. These are the three main important techniques. Another technique would be simply kissing balloon inflation. You simultaneously kiss, then you take out the side branch balloon and wire and address the main branch with proximal optimization technique.
But during these latest years, the drug, the coated balloon is used as mostly maybe in the normal region of the the bifurcation, the left main bifurcation to use to protect the side branch. What do you think this the treatment?
Yes, I agree with you. The concept of drug-eluting balloon is very good, but we lack data in terms of benefit. So we need more and more trials. But as you are right, I mean, side balloon can be used in side branch as a provisional technique. So then it will be followed by proximal optimization in the main branch. It can be used, and it is a good technique actually, but then it requires more and more data.
I think up till now we have no solid evidence to support the DCB balloon to use for the protection. But after after the gel balloon technique, maybe we use the DCB balloon to treat after the main stents implanted. Maybe a good idea.
Yes, that is a good idea. Even the concept came long back uh, from I think Italy, but then then Germany. And in your country also, China, a lot of drug-eluting balloon is used. Some few trials are there, I think. One is a beyond trial. I remember that side branch result is good with drug-coated balloon. That is a multi-center randomized controlled trial in China, I think, published
Mhm.
this year only.
Yes, because we have the much cheaper the Chinese DCB.
Okay.
Yes, can factory to support us to do some research, but in present, in my experience, I think I have few experience to use DCB in this status. I think maybe it's a. I agree with you. Yes, the maybe it's cheaper, maybe more experience for me.
Yeah, it may be cheaper, but it may work well when you don't want, another stent layer, and
Mm-hmm.
when you want to use it in patients with high bleeding risk.
Mm-hmm.
And another thing is, sometimes you cannot use many stents.
Yes, yeah, yeah. For bifurcation lesions, what should be done when side branch occlusion occurs after main branch stent is inserted?
Yes, when there is side branch occlusion following the main branch stent, the first thing is, exchange the wire and kissing balloon inflation,
Mm-hmm.
or pot side pot. Proximal optimization, then side branch inflation, then again proximal optimization of the main branch.
Yeah.
If it doesn't work, then we can think of second stent
Mm-hmm.
in T and protrusion, provisional culotte, and internal crossway.
Mm-hmm.
So these techniques, actually, the selection of the technique depends on the operator experience, the angle of bifurcation,
Yeah.
and the diameter of the side branch.
Yeah.
If the angle is more 90-degree or more, then T-stenting is very good. Uh, if you do other techniques with 90-degree angle, there will be malapposition of the stent, main branch stent.
Mm-hmm.
But however, T-stenting suffers from incomplete coverage of the side branch ostium, leading to incomplete side branch scaffolding, leading to restenosis and instant restenosis. That is one thing. Second, if the angle is narrow, then we can think of T and protrusion. So side branch and another stent is inserted into the side branch with few millimeter protrusion into the main branch. Then you do, kissing and pot afterwards. In this technique, however, there may be a neocarina that may lead to stent thrombosis. We do not know actually.
Yes. Yeah.
Another technique is a provisional culotte. You can do a mini culotte and with less overlap, mini overlap of the stent with mini kissing. But sometimes it will be difficult to recross the two stent layer at the carina. But these techniques should be done when main branch, side branch are of similar in diameter and angle is narrow.
Mm-hmm.
But another is internal cross. The data is not available, so I am not highlighting that.
Yeah, we usually maybe we should assess the bifurcation lesion before we perform our procedure. So I think you are give us the good suggestion and advice to do the bifurcation. So
Yeah.
I agree with you. I don't like reverse Q dot. I like
Yeah,
Q dot.
yeah, that is exactly. That is a good technique actually. I think next to decay cross in some situation you will like reverse culotte.
Yes,
Yeah,
yes,
that is
yeah.
inverted culotte. That is a good technique.
Yeah, the last question. In the future, is DCB angioplasty for both main branch and the branch vessels a new trend in clinical treatment of bifurcation lesions? Do you think so?
Yes, we need more and more data in future. It may come. You can treat main branch with DCB only. This is called only DCB strategy.
Mm-hmm.
So DCB on the main branch as well as in the side branch. This is one strategy.
Yeah.
There is provisional strategy, DES in the main branch and DCB in the side branch, like provisional stenting. So, the second one, I think there is a randomized study in the Europe, that is David Pro David study, that is looking whether, proximal, what do you call, the provisional DCB technique is superior to the provisional stenting technique or not. Regarding only DCB strategy, I don't have data, but it might come in future, and we may be surprised, because nobody wants stent metal inside the body. Either some, by what do you call, bioobservable stent should come, or DCB should come to take care of bifurcation.
Yeah, I think we have maybe much more new device to do and perform PCI in the maybe in the very latest future. But I think DCP just one of our choice. We have more choice, I think.
Yes, yes.
Yeah.
I think BBS is another device, like bio reobservable stent, BRS. That is another one. It may come in future with thinner strut, so that accessibility, side branch accessibility, some technological innovation may be there in future. This is what I predict.
Yeah, yeah. Thank you.